Okay, so I'm going to talk about what's new in developmental and epileptic encephalopathies. And these days we always show our disclosures in talks. And just to say, I work with many of the pharmaceutical companies. The ones as the investigator is the one that really matters from your point of view, because that's where I might ask you if you're interested in participating or your child's interested in participating in a trial. And just to let you know that any money from those trials goes to support the team. I do not take money from those from being an investigator. All right, now I'm going to start, well, firstly by thanking you, because all of this work that I'm going to show you could not have been done without your help and very usually your enthusiasm, and I'm really grateful for that. And your children teach me so much about these disorders and help me think about the next important question. The other thing I wanted to say is I'm actually giving you the talk I gave in Israel last week and in America in December. Actually, it's a little different because there's an extra study in since the American in December one, but I gave this in Israel last week. So it's very much at a medical level, because I know parents like to hear it as it is. I'm going to go more slowly and hopefully put it into English. I certainly don't mind if someone comes on and says, Ingrid, what does that mean in the middle of something? Because if you don't understand, no one else will. And I'm trying hard to remember not to use too much terminology. Now, this is the outline, and these are all very recent studies I'm going through. So they're all sort of hot. Most of them are in press or under submission with journals. So you haven't heard them before because I haven't talked about them before. There's one slide of there's one talk about the risk of a second affected child that I have presented before, and I'm doing that intentionally because I think it's a very important point that people might not think about. So here's a list of things we're going to go for. We're going to start off with definitions. What does developmental and epileptic encephalopathy mean? And I know many of you have heard me talk about this before, but I can also tell you that doctors still get it wrong all the time and don't grasp the essence, the very meaning here. So I always go through it with the doctors as well. I'm then going to tell you about some new work I've done with a PhD student from New Zealand, looking at the epidemiology, which means how frequent are these disorders out of New Zealand. It was a New Zealand group that we studied. I'm going to tell you then about how many genes do we have for the DEEs. So I'm going to call these developmental and epileptic encephalopathies, which I'm sure you will all agree is quite the mouthful. And unfortunately, I was behind that title, so I have to wear it, but we're going to call it the DEEs because it's a bit long to say all the time. I'm going to tell you about a new study that's just about to come out in one of the journals in the next week or so, looking at genetic DEEs and the different risks in different gene groups about status epilepticus, which is a seizure lasting more than 30 minutes, the mortality risk, and the SUDEP risk, which is sudden unexpected death in epilepsy. I'm going to tell you about a very recent study that's submitted but has not been reviewed yet to a journal of DEEs with movement disorders, and many of your children have got movement disorders, but these have been under-recognised. And then the last bit is quite heavy-going genetics. So if you're exhausted by then, you can stop listening, because I'm going to go into mosaicism and how do we know that 50% of the children and adults with DEEs, we know the cause, and then we move from there to how do we develop new therapies. But we know 50% are still not solved. And one of the issues here is something called mosaicism, which I'll explain, and then complex inheritance, which is right at a very complex end. But I'm sure you can listen till you're sick of listening, really. So when we talk about DEEs, we're really talking about three different factors. The cause, etiology is the medical word for cause, the epileptic activity on a child's EEG, and the impact on the child's development. So in an epileptic encephalopathy, and infantile spasms are always an epileptic encephalopathy. And here you see a beautiful little Indian girl I look after, who's actually a twin, and she's having spasms when she stretches her arms out. And I'll say yes when it happens so that you can see it. There's one. And if you look at her face, there's often a subtle facial change with this spasm. And this is a video the parents took, and there's another one. Now, these little attacks look very brief, but they are quite worrying when they occur. And there's another one. And they go with a very nasty EEG with lots of epileptic activity. And we know that this, oops, I'm just trying to play it again and I went too far. We know that this epileptic activity actually causes, oh no. Can you still hear me? You haven't lost me, have you? I just got an error message. Okay, Chris?
I can still hear you.
Good. So we know that the epileptic activity, this hypsarrhythmia, actually affects the child's development, the baby's development very commonly, but these spasms can keep going through life. And the child often loses abilities or may just stop developing. So that's an epileptic encephalopathy, and we have many different ones, not just one, but infantile spasms, epileptic spasms syndrome, or West syndrome is the old name, is one of the most frequent ones. When we looked at the terminology, we added in a new term, developmental and epileptic encephalopathy. And I saw there are quite a few of my Dravet families online, so thank you for tuning in. And you know that Dravet syndrome is sort of the prototype. It's the one we always use, or the poster child for the developmental and epileptic encephalopathies. And children, more than 90% of children and adults with Dravet syndrome have an abnormality in this part of the sodium channel here. And here you see the cell membrane, the sodium channel in it, and here's the alpha-1 subunit, and this is the one through which the sodium ions go through in and out of a cell. And this subunit is called, the gene encoding it is SCN1A, another one is SCN2A, another one is SCN8A. But in 90% plus of children with Dravet syndrome, they have an abnormality of this SCN1A. What we realized was that a lot of the problems in Dravet syndrome weren't just due to seizures. And we realized that this SCN1A abnormality caused slow development or intellectual disability. And then on top of that, they had the epileptic activity, which also impacted development. So the child had intellectual disability due to both the cause, the sodium channel abnormality, and the epileptic activity, so two processes. And one of the reasons we realized that was that sorry everyone, I just went fast too far. I wanted to show you this young man that who I look after, and you can see he's got this very severe crouch gait. He's about 27, he's got Dravet syndrome. It's not his seizures that are doing this, it's the sodium channel mutation. And not all Dravet children and adults get it, but I would say a good 80% or so do, just from my experience. Now, I wanted to contrast this developmental and epileptic encephalopathy from the other side of the coin, which is where you just have intellectual disability. So you have your cause, such as a particular gene, CUX2 might be one, for example, and you have epilepsy, and you also have intellectual disability, but the epilepsy is not causing developmental slowing. So I'm just using that as an example of a different group of patients. And I'm going to tell you a little bit about the frequency in a moment, which is why I wanted to separate them out. Now, I use this slide also to describe the term developmental and epileptic encephalopathy, because so many of the doctors don't understand it. And I feel like if you keep explaining it, maybe it'll be clearer. Something I will say will make it clearer. So here is a little boy with a potassium channel mutation, KCNQ2, and he has severe developmental problems, as you can see, because he's in a walker. And that is caused by the potassium channel mutation. He then has a very severe epilepsy on top of that, which began in the newborn period and then has evolved into a different epilepsy syndrome now of Lennox-Gastaut. One of the problems is that knowing the gene isn't enough. because a gene causes a range of different phenotypes, which is a medical word for presentations. And some of those presentations might be milder than others. So you really need to understand both the cause, which is the gene, and the presentation, which involves understanding the seizure types and the EEG and the MRI. So for every patient, I think one needs to get the cause, and we know that at least 50% of this group of children and adults have got a gene cause that can be found in 2023, and they usually have an epilepsy syndrome that we can find as well. So I'm not going to spend too long on the epidemiology, but just a few slides. And this is some previous work I did with my PhD student, Catherine Howell, and I'm sure she looks after some of the patients who are on the call. And this is from her PhD, where we looked at onset under 18 months of age of seizures. Now, this structure of this study meant we did not include Dravet children, but there was a 1 in 2,000 frequency, or incidence is the word. Another study from my colleague Samir Zuberi in Scotland did it in the whole of Scotland, and they were all seizures, and they also found around the same figure. Now, in the latest study, which is from Gemma Polk, who is a PhD student and geneticist in New Zealand, and I've supervised her together with Lynette Sadlier, who's also a paediatric epilepsy specialist. And this is the area in green in Wellington, New Zealand. And the ascertainment for this, so that we thought we caught everybody with severe epilepsy, was EEG studies, because Lynette reads all the EEGs for that part of New Zealand. When you look at epilepsy and developmental impairment or intellectual disability broadly, it's 1 in 340 children. And then if we compare the children with the developmental and epileptic encephalopathy versus those with just straight intellectual disability and epilepsy on top, the developmental and epileptic encephalopathies are more frequent, with 1 in 592 children versus 1 in 800. Now you can say, well, that doesn't mean much to me, and I know that, but what it does mean is this is important to go to government and policymakers around making adequate resources, because for the first time we understand the frequency. We understood under 3 years of age, but we didn't understand through childhood up to 15 years or up to 16 years. The other part that's interesting is when you look at the development with age, you can see that the younger they are, there are a lot more DEEs, whereas the intellectual disability plus epilepsy children just keep increasing over time. So they have intellectual disability and then they get epilepsy along the way. We found that the DEEs were associated with more severe intellectual disability. It doesn't mean you can't have severe intellectual disability, but overall this group was more severe. And the earlier the onset, the more severe intellectual disability that was likely to be statistically. So that doesn't refer to one patient, but refers to the group as a whole. So moving on then, within the DEEs, we have a whole lot of syndromes, and I showed you the little baby with infantile epileptic spasm syndrome. I showed you the older man with Dravet syndrome, but there is Lennox-Gastaut syndrome, epilepsy with myoclonic atonic seizures, used to be called DOSA or DOOS syndrome. Here are some much rarer ones: epilepsy of infancy with migrating focal seizures, developmental and epileptic encephalopathy with spike wave activation in sleep. Some other rare ones, tuberous sclerosis you may have heard of, some that begin older in older life. But there are many patients that can begin in the blue bits and don't fit into a neat syndrome. And we now call those beginning under 3 months of age early infantile. And that is a very important group because they often can have quite severe disease. And here is the incidence of each of these syndromes. You'll see infantile epileptic spasm syndrome is the most frequent at 58.2 children per 100,000 children. Epilepsy with myoclonic atonic seizures, 16.4. Lennox-Gastaut, 13.2, and Dravet is 5.1. So although Dravet syndrome is the one we talk about a lot, some of the others are more frequent. I think I'm going to go past that and just go on to the next study. And this is really about the number of genes that we can that can cause the DEEs. And I've already mentioned that we're solving 50% of these, of finding the cause in 50% of children and adults with DEEs. And this picture is from a review that I led about in 2016, so it's quite old. And this is a nerve cell, a neuron, and these are all different genes that have been associated with epilepsy and a whole lot of different processes in the cell. I'm not going to go through them because they're very scientific terms, but I'm sure there are some science parents there. What I did want to talk to you about is that Karen Oliver, who's worked with me for about 15 years, first as a research assistant, and now she's towards the end of her PhD as a bioinformatician. It's a big word. What it means is they're looking at all the genetic information, the gene code, and finding the cause. And what she's done is look at all the epilepsy genes that are out there. And we've been saying 100, 400 for a while, but we were way under in terms of single gene epilepsy. So where you have an abnormality of that gene that gives you epilepsy, you don't need anything else, just that one gene abnormality. We now have 926. And over 800 of these cause a DEE. So this is the most important group by far. And this is Karen, and she's just on maternity leave with her second little girl. So she's done an amazing job so far with her PhD. And one of the things was she compared 4 of the different gene panels, and she showed that these panels, and some of these are not available in Australia, more in America, but just to show you that these gene panels that we test vary greatly from 144 genes in the panel that's used or to up 511. And only 111 of these are on all 4 panels. So one of the problems is if you have a panel that doesn't have your child's gene on it, it won't be picked up. So it's always important, if you don't have a cause for your child's severe epilepsy, it's really important to go back and ask again and get the data to be analysed again, depending on the type of testing that was done. So we need to reanalyze the data if you don't know the answer in your child. And you have to ask your neurologist or your geneticist that. And Karen looked at the 926 genes that you only need an abnormality of that one gene to have epilepsy. It's not like a whole lot of genes, and I'll come back to that later. And while I've been teaching for many years, as have my colleagues, that most of the children with DEEs have an autosomal dominant gene, we're actually not right. And what autosomal dominant means is you need to have just a gene that can go from generation to generation. However, mostly these children have a new gene mutation in them. So that means this abnormality started in either the egg or the sperm, and we don't usually know which, or even after the egg and the sperm got together to make the baby, somewhere along the way after that, the abnormality occurred. And we thought that they were mostly dominant, but it's actually only a third, and over a half are recessive. And that means you have 2 bad copies, a bad copy from mum and a bad copy from dad. And it's just bad luck that they married or they partnered with somebody else who had a bad copy of the same gene. But it does change their recurrence risk quite a bit. And then as well as that, there are some on the X chromosome and some that are mitochondrial. Happy to answer questions about that, but I won't dwell on that too long. And one of the things that we found that was new was that one gene can cause both autosomal dominant and autosomal recessive inheritance. So we have to think a bit differently about the genes and the presentations of the children. I'm going to take a breath and we'll go on to the next study. Now, this is a study led by Alice Donnan, who is a lovely general paediatric registrar, also on maternity leave at the moment. But she came to me and wanted to do a project. And I knew that I was sitting in the clinic thinking, does this child have the same risk of status epilepticus as the next child? And what do I tell parents? So just to define that for you, status epilepticus is 30 minutes at least of continuous seizure, or having lots of little seizures and not coming around between the seizures. But it comes in two flavors: convulsive status epilepticus, where you're having like a full convulsion or a tonic seizure and you're stuck in that very nasty seizure, and that can be very much life-threatening. But it also comes in non-convulsive status epilepticus. And what that means is you might have 30 minutes of just sort of lying there, not being very with it. You might dribble more unsteady. You might not be able to walk around as usual, might need support. And they're both very serious. And really, if you can't control them, the child often needs to go to the emergency department. Now, I'm sure that the parents on this talk, on this webinar, are aware that many of these DEEs have an increased mortality risk. And just to give you an idea of that, and I know I've discussed it with the families that I see, the mortality risk for Dravet syndrome, as our poster child, is 17% by 20 years of age, which is frightening. That 17 out of 100 children will not make 20 years, but the upside is that 83 out of 100 children will, but it's still very scary. And one of the most common causes for the risk of death is called SUDEP, which is sudden unexpected death in epilepsy. And this is where someone is just found usually having passed away in the morning. And I know that's every parent's worst nightmare. And so what I was asking myself was, well, is this gene got a risk of SUDEP or just this gene? And that's important because parents are terrified about it, and I completely understand that. So what we did was we looked at all the patients that we had on our database. And again, thank you for supporting our research. And we only chose where we had 10 patients with one particular genetic DEE because we wanted to have enough to start to see some patterns. Now, we had a lot more Dravet because of my Dravet interest. And in this study, we had 203 Dravet patients with SCN1A mutations. The only gene that's there twice is SCN1A, because it can also cause a more severe DEE than Dravet syndrome. And you'll recognize the other genes. Remember, not everyone's gene on the call will be there because we needed to have 10 individuals with that particular gene, and you can see if your gene is on there. And what do we find? Well, firstly, in the whole cohort of 510, the median age was 10 years, and most of them were children or adolescents, because that's where a lot of my practice is and a lot of the patients that we've have collaborated in our research program. But you can see the range from 1 month of age to 79 years. The median age of convulsive, so that's where you're having the big convulsion, age of onset for convulsive status epilepticus was 8 months. Now that will be skewed a little because we had so many Dravets, and as many of you will know, Dravet syndrome typically begins at 6 months, but can begin up to about 18 months of age. But that's why that's so close to the Dravet onset. I thought the non-convulsive status epilepticus was actually in a way more interesting because the median onset of that was 5 years. So I do get calls, and I saw an Angelman family just on Monday, and we were talking about it because they were saying, we were talking about how they recognized when their beautiful little boy had non-convulsive status epilepticus. And they rang me and went to the emergency department of a children's hospital, and we had to talk, make sure the doctors realized that he had non-convulsive status epilepticus because he was not with it and he was dribbling and wasn't right. So here are the data from this study. I'm sorry it's a bit of a complicated slide, but you can see in the purple the convulsive status epilepticus in the total, in the whole cohort of 510 patients, almost 50% had convulsive status epilepticus. And in the non-convulsive status epilepticus, it was in about 20%. But then that's all not that meaningful in the big cohort of 510 patients. Cohort is big group, sorry about using that's a medical term, isn't it? But in the Dravet patients, we already knew that they are very prone to this convulsive status epilepticus, which is life-threatening, and we found that 90% had had that, but only about 25% had had non-convulsive status epilepticus. Now, for the parents who are online and have SYNGAP1 children, there were no convulsive status epilepticus, but they did have some non-convulsive status epilepticus. And again, I encourage you to look at your particular gene. Angelman syndrome is non-convulsive status. Neck-Smith is non-convulsive status. The non-Dravet SCN1A are both, but you can see how much it varies according to the gene. So this, I think, will be very useful information for neurologists and geneticists. Now, what about the mortality? In this cohort of 510 patients, 8% of them had died at a median age of death of 7.4 years. And here you see more of them had SUDEP, sudden unexpected death in epilepsy, than other causes. But you can see that there's really a good amount of both, or a bad amount of both would be a better way to say it. Status epilepticus, so that's a prolonged seizure where you may go into multi-organ failure, was the cause in some. Brain swelling in some of those, and we described this in Dravet syndrome some years ago, where a child with Dravet syndrome, and they often have prolonged seizures, suddenly had a prolonged seizure and their brain swelled, and then they didn't survive that seizure. And then there are other causes which are listed here: respiratory infection, drowning, etc., withdrawal of care. But that's unusual to withdraw care. Now, what about the genes? So SCN1A is the biggest offender here, as we'd probably expect. And you can see here all the blues are SCN1A SUDEP patients. But 4 of them were this much more severe, this profound early infantile SCN1A-DEE. What else? SCN2A, there was one SUDEP with SCN2A, one with SCN8A at 8 years here, and then one with STXBP1. And if we have any parents of a child with STXBP1, you'll know it's a very severe disease. So here is what we found in this study, that there are different risks of convulsive and non-convulsive status epilepticus and SUDEP in different genetic DEEs. And I like to think of these genetic DEEs all as different diseases. So 825 genes, 825 diseases. And it can be even more than that, because one gene may have several different presentations. So here are the genes that are most likely to be associated with convulsive status epilepticus. Now, why is that not advancing? There we go. These are the genes most likely to be associated with non-convulsive status epilepticus. And these were the genes in our cohort that were associated with a mortality risk due to sudden unexpected death in epilepsy. So understanding these risks informs our ability to care for the child, both in terms of counselling families. Is this likely or not likely in your child, and how should we manage it? For example, should we have a camera in their bedroom, such as a SAMI camera? It helps parents to diagnose more rapidly. And this is really true for non-convulsive status epilepticus, because this can be missed easily in these very severe kids. And if the parents know what to look for, they know when to come to, they know how to treat it at home. And if that fails, how to come to the emergency department and get more aggressive treatment with intravenous drugs. And if you can control these episodes of status epilepticus and non-convulsive status epilepticus, both convulsive and non-convulsive, then you might help the outcome, because often they will cause the child to go backwards, which is the scary thing.
Ingrid, we just had one question before you move on from Jess, asking how would you identify the difference between non-convulsive status and post-ictal phase?
Great question, Jess. So the first thing is knowing your child and knowing what they're like after a seizure. So after a convulsive seizure, the person will usually go very floppy. Their breathing might become because it all goes floppy in their airway, and they will sort of relax. In non-convulsive status, doesn't usually follow status. So if someone's had convulsive status, I think this will be the Jess that I know. So I know the right syndrome. And in non-convulsive status, so there are 2 issues I wanted to point out. One is convulsive. Often the ambulance, well, not often, sometimes the ambulance officers might think it's finished and the parents will know it's still going. And that's always very scary. I can see you nodding there, Jess. And I think one of the ways I think is very helpful is if you open the child's eyelids just gently with your hands, I hope you can see me, then you can see if the eyes are sort of in the midline and not deviated and up, they probably are no longer fishing. If they're still deviated up, even with them closed, but you find they're up, then they're probably still fishing. And then you need to tell the ambulance officers that you think they're still fishing, and can they get you to the hospital ASAP? And can you get the doctors, and you might need to upskill them. If it's non-convulsive status, you don't usually have fixed eye deviation. You could with focal, but it's unlikely. It's more this sort of general drooliness, half-witheredness. It looks a bit different. And I think in a way the parent becomes the best expert. But if you're not sure, do some videos and ask your neurologist. That's what we're there for. All right, now I'm going to go to the next study. And I think I'm going to leave out the very last complex inheritance ones because it's very, it will take me a long time. I'm not sure it's going to be as practically helpful, but I'm going to keep going with all the other stuff. So this is a new study, which is currently under review. And I just wanted to highlight, this is Stera, who came from the Netherlands, and she's a medical student who is finishing her PhD. And she's going to be fantastic. She's extremely talented. And she was with us for 6 months. And she's doing her PhD is in movement disorders. So I asked her to help finish this study, which was started by an adult neurologist called Gabriella, or Gabby we call her. And she's an adult neurologist at the Austin. But she'd started it, but we needed Stera to get it across the line. So this really addresses the question of movement disorders in patients with DEEs. And I began to realize that while people like me are very focused, Kelly, thanks, Kelly. And what happens is that we're all very focused on the seizures and how we're going to get the seizures under control. And slowly but surely, I started seeing more of these kids actually had some movement disorders. And you could say, well, why does that matter? Because we need to figure out, are they seizures or not seizures, because we have different treatments, different managements. Do they need medication for seizures or for movement disorders? Often we don't treat movement disorders unless they're severely debilitating. And then what treatment would you use? Anti-seizure medicines, medications, and there are other things you can do for movement disorders. So that's the background to the study. And the other things I was talking about are like deep brain stimulation. They're not small matters, they're big matters. So in this study, we hypothesized, which means we thought that the specific genetic DEEs would be associated with specific types of movement disorders, and that these movement disorders might reflect the biology of the disease, what's going wrong, why this gene is causing it. And why does it matter? Well, you know, there can be issues that we need to differentiate, such as this lovely pair, brother and sister. They've got a very severe disease called Dynamin 1D and M1 DEE, and they had spasms. But you can see, particularly, they've both got a movement disorder, but the little boy's is just terrible. He moves the whole time. In fact, it's so severe the parents can't get on a plane to bring him to visit me. Now, the question that people might ask is this a movement disorder or are these myoclonic seizures? And that might need an EEG or other ways to figure that out. And these are just some other examples. CDKL5, they often have stereotypies like this sort of movement. Many of your children will have those, and they're not seizures, but people can be confused. And if you're confused, you might treat them inappropriately. And GNAO1 is another one which can have very severe dystonia. I don't know if you can see me, but that's funny posturing. Again, you need to figure out, is this dystonia, a movement disorder, or a seizure? So this is, in this study, we had 77 patients where we knew the gene and we knew they had a movement disorder. They were aged 9 years at a median, but between 1 and 38 years. The movement disorder began typically at 18 months, but could begin as late as 35 years. And of the 77 patients with the movement disorder, 3 had died. I don't think that was due to the movement disorder, just to be clear. And you can see the most common are these stereotypies, and that's like hand flapping, but you can have all sorts of stereotypies, and they're involuntary movements, so you don't want to do them, they just happen all the time, and you can't tell a child off because they don't even know they're doing it half the time and they can't control it. Now, there are some that are normal. I remember with both my sons that when they were about 5 or 6, they had it if they saw a train set, very exciting, and then they learned to control it. But with the DEEs, often the kids might have it more severely than that. A dystonia can be very painful and therefore need treatment. Chorea is little movements. Myoclonus is both an epilepsy and a movement disorder. Ataxia is unsteadiness. I think everyone knows what tremor is. And hypokinesia means you don't move very much. And we found that the dystonia was more likely in children that never walked, and the unsteadiness was more likely in those that did walk. But I think that was because they could walk, so we could identify it. So the second point isn't as important, I don't think. And then this is a complicated slide, but just to say that half of the 77 kids just had and adults had a single movement disorder, but others had a combination of more than one. So stereotypies were the most common on their own in 18 people, but then they also occurred with other types of abnormalities. So here, like 9 had dystonia. And then in terms of movement disorders and intellectual disability, some of these were most prominent, were sort of seen from moderate to profound disability stereotypies across all of them. Same with dystonia. Chorea was more obvious in the profound group, those like the little sister of the boy I just showed with the very severe movement disorder, and ataxia, the unsteadiness, was more common in the mild end. And here you see the gene groups of the patients, and these is where we had more than 3 patients. And this is just to say with STXBP1, stereotypies and dystonia was seen, CDKL5 stereotypies, SCN1A unsteadiness, ataxia, SCN2A dystonia was very common. And then we tried to have a look at which movement disorders went with which problems. And here you can see the channel disorders, which are the gateways into the cell. I showed you the sodium channel before. The sodium channelopathy and the potassium channelopathy and synaptic vesicle trafficking, that's to do with letting cells substances in and out of a cell, just a normal cell activity. These were most likely to have dystonia, which is your light green. And you can see here that the sodium channelopathies, that will be a lot of the SCN2As, were likely to have that. And then when we looked at all the others where the child had transcriptional problems, which means they couldn't make proteins, they were more likely to have stereotypies. So what about therapies? This is a little girl with SCN2A dystonia, and she had the worst dystonia I've ever seen, actually. She had it for 18 months, and then we put a pump into her spine of baclofen, and it made a huge difference. This is her here. One boy had deep brain stimulation with a GNAO1 DEE, and then you can see here a range of different treatments for dystonia. In general, stereotypies, tremor, and lack of movement were not treated. And that's because we don't have really good treatments. In many of the patients, we didn't really know what they were treated with. This was sort of just looking up their records. And here are some of the drugs that are used. And here you see the deep brain stimulator, that the idea there to stop this very severe chorea and dystonia. This stands for deep brain stimulator. So concluding this study, we found that movement disorders were under-recognised in DEEs more generally. It can be hard to tell the type of movement disorder. And just to point out that a movement disorder neurologist is different to an epilepsy neurologist. So you may need to see a different neurologist to understand that more, but many people can see both. There is a limited amount of correlation with the type of gene abnormality. The best thing you can do is use your phone. And I always say to my families, I'd like 3 examples of whatever you're worried about, because then I can see how much they look the same. And the medical term for that is stereotyped. It also allows me to look at what the child's doing when they develop their movement disorder, and are there any particular triggers to it. So that really helps with diagnosis. And the problem is it a seizure or is it a movement disorder? And I saw one of my 21-year-olds yesterday who has a mitochondrial problem. We haven't got her gene. She's nonverbal. I think she crawls around at home, and she's always had quite an obvious movement disorder. But the mum came to see me, great mum, and said, I'm worried because her seizures are worse. And she had a SAMI camera in the room, and she showed me the camera on the bed, and it was clearly a seizure. And she's been a girl that we've always had to be very careful to figure out what's movement disorder and what's seizure, and this mum is really good at that. So we need more numbers in our studies, and then we need to think about precision treatments for these genetic causes. Okay, so now I'm going to get on to the genetics part. This is more about solving the remaining 50%. So is our cup half full or cup half empty? I don't think it's all about the genes. I have said to many of the families on the call that I think finding your child's gene is the beginning of the answer, but the answer would be a healthy child, and we're a long way from that. So I just want you to know that I'm not just focused on that, but this is the beginning of trying to get to better treatments. So what about the ones that we haven't solved? And this is sort of below the iceberg, the remaining 50%. I'm not going to go into this in any detail, except to say that there are parts of our genetic code that we still don't know how to interpret them. And we're learning all the time. The genetic testing is getting better with what we call genome sequencing, but we've still got 50% to go. But I do want to talk a little bit about mosaicism, because I think it's super important. And it's lovely speaking to an Australian audience, because you all know this is an Indigenous Aboriginal painting of a lizard. And I love it because it shows really what mosaicism is about. A mosaic, I know you all know about that. And a mosaic is where you have different little tiles, if you will. And the idea here is you have normal cells and abnormal cells. So if you have a look at here, we're going to talk about 2 sorts of mosaicism. And this is the part I have presented before, so some of you might have a sense of déjà vu. And in mosaicism, you have normal cells in the baby, in the early embryo, and in the human when they will turn into a big person. And the blue are normal cells, and the orangey browny color here is an abnormal cell, a mutation cell. Now, if there's just a few small proportion of cells in the person's body, they might be completely normal. And if that abnormality is limited to their eggs or their sperm, if it's the mother or the father, then you can imagine if that egg or sperm makes the baby, it'll be in every cell in that baby, and you'll get an affected baby. So mosaicism, this is the study we published in the New England Journal of Medicine in 2018, where we looked at 154 mother, father, and child, where we knew the gene in that child. And we said, does that parent, mum or dad, have a low level of abnormality that's the same as their child's abnormality? And so we started with 30 families where they had an abnormality in one of 33 genes. So every family only had one gene abnormality in their child, but we looked at the parent for that child's gene, their child's gene abnormality, and we looked at the parent 200 times to see if the parent might have just a tiny amount of the abnormality in their cells. The first thing we found when we looked at the children, the 3 of our patients, 3 of the children were mosaic, and they had between 25% and 32% of their cells rather than 50%. And here are the genes in those 3 children. Now, what that means is important for the families because it means the child had normal cells and mutant cells, which means the abnormality happened after the child was formed because they had some normal cells. And that means the recurrence risk for the parent is very little, very, very, very low likelihood. On the other hand, if the parent has a low level of cells, then you know that they've got a higher recurrence risk. And you've already seen this little brother and sister, and you can see here the sister, neither of them walk or sit or talk. So they're very severely impaired. And the mother, they had the little girl first, they were told they're very low recurrence risk. And then they had the boy who had the same thing. And then you know that one of the parents must carry it at a small proportion and the parent is mosaic. And it could have been the mum or the dad, equal likelihood. And the parent was 6% mosaic. So what did we find in this study? That 8% of the children that we studied, the 120 children, had a parent who was mosaic. And that puts those parents at much greater risk, that family at greater risk of having a second affected child, which you can imagine would be incredibly difficult. And I'm sure you all would understand that more than I do. And we realized that the percentage of parental mosaicism has been underestimated, and that we need to look at this very carefully because parents need to understand if they've got an increased risk of having a second affected child before they have that child. One of the flags that the parent might be mosaic is if the parents had seizures, even just febrile convulsions or febrile seizures. And we found that if the parent had higher mosaicism, I have one dad who has 28% mosaicism, and he's got a boy and a girl with Dravet syndrome, and he's of normal intellect. So reproductive counselling is essential. And if you're a parent with a young child with a DEE and you're thinking about further children, then I think it's really important to ask to see a geneticist. Now, I think I'm not going to go on because I'm worried about questions. Do you agree with that, Chris?
Yeah, I think we've got a couple of questions that are sort of sitting in the chat. So yeah, we can
I'll bow out for a moment, and then if we run out, I can always talk a little bit more.
Sure. So I'll just hand over to Anthony first, who had some questions around the keto diet and its impact. You're just on mute, Anthony.
Perhaps the most appropriate question is, you've mentioned medications that can be used to help treat seizures and or movement disorders, but where might a ketogenic diet come in, and is that diet more useful for certain gene problems than others?
Oh, great question. And one of my major interests is the ketogenic diet. So thank you very much for asking that question. The ketogenic diet can certainly help lots of people with drug-resistant or uncontrolled seizures. And it is important that it's part of what you can offer a family. It's particularly good for the syndrome called epilepsy with myoclonic atonic seizures, also known as DOSA. Well, the old name is DOSA or DOOS. And that's where one should think about it very early on. Maybe you try Epilim and clobazam or something, and then you go to it. But having said that, I will certainly offer it to all my families with children and adults with drug-resistant seizures. There are some really important caveats. So although I'm really keen about the diet, many of the kids won't tolerate it. And that's either they're already a nightmare to feed, and I would say that's the case for many of my Dravet patients. They're very fussy eaters, or the other side of the coin is it's their one passion in life, and mum and dad don't want to change their diet because they love their chips or whatever it is. Sometimes what I usually do is I raise it, and then the parents tell me when they're ready. So I keep offering it, but equally, it is a big change socially, psychosocially for the child. Now, if you've got a very severely disabled child if they've got a peg, for example, that's a gastrostomy into the stomach, a hole into the stomach, and they're not eating much, it's much easier because you have a formula you can use. One of the other things, but we also use it for other people as well. One of the other things that's really important is you need a diet support team. So you need a dietitian. My nurses are incredible. In fact, I think I saw Briley was on before, but we have our paediatric nurses that help us, and they are really a huge benefit for helping us to manage the diet, because they work with the families and are more available, and they like Briley will come to me 3 times a day with different queries for different patients. So I think it's important to have the diet well managed, and my view is it's not just a dietitian that should be doing it on their own, but should be doing it with their neurologist, and ideally if you have access to a keto nurse, it's a wonderful thing, a keto nurse. The other point is that you can use it in adults, Anthony, and again, the adults I've had less success with because they're more, if they're higher functioning, they're more interested in going down to the cafe and having, food or the pub. And so that's more of a challenge. And we've moved from the classical ketogenic diet in adults to just the modified Atkins or modified ketogenic diet is the way we call it now. But it is certainly something we should have. And I think it's important to try it once and try it well for 3 months. If you're going to try it, don't half do it. Do it properly. See, does it make a difference? And if it doesn't make a difference, then, because it takes quite a bit of time and effort. I always tell parents it's the first 3 weeks that's the hardest. And then after that, once they know what they're doing, they're experts, they can freeze the meals and they manage really well.
Thank you.
Thanks, Ingrid. And then we've got a question from Alicia about how do movement disorders and stimming differ. Alicia, if you want to elaborate. You still here?
Yes, sorry, still here. Yeah, we just have a lot of stimming, and so it's sort of uncontrollable but controllable, depending on how receptive Arden is to it. So I'm just sort of curious how that differentiates from probably just one of the aspects of the movement disorders.
So, Alicia, I suspect that what you're calling stimming, I'm calling stereotypies, just to be clear. And with stereotypies, you normally can interrupt them, but when the child's bored or excited, they might go back to it. And then if you interrupt them and you give them something to eat, they might be all right, and then they'll go back. So I think that's probably what you're meaning by stimming. Does that sound right?
Yes. Yep, that sounds pretty accurate. Thanks.
I do think that's part of his, it's exactly what I'm talking about, actually, the movement disorders in this study.
Yeah. We've got 2 more questions in the chat. One from Chris, if you'd like to present your question to Professor Scheffer. Can't see Chris. You still here? I'll just read it out. I'm not sure if
well, maybe let's do the next one first if he's not there, because it does sound like it's half of a consultation, which is probably not the right thing to do.
Yes, having trouble with his mic. So another question from Jennifer was, are there wearable sensors that can pick up if a child is having an absent status seizure at night time and reduce the risk of student?
Are there wearable sensors? So absence, not so much, because we don't have unless you happen to be having an EEG study. So not really absences, but these SAMI cameras that I mentioned, a number of, particularly my Dravet families, but some of the others as well, are getting them. And they seem to be very good. I think you have to get that balance between false positives, waking up mum and dad all night long, and really picking up enough movement for a seizure. And the beauty is I'm sure the parents on the call know more than I do about this, but in the morning you can review it and look and see if you've missed some seizures, which is also useful in terms of understanding the seizure frequency. But the big wish, the real reason you want it is you want it to be able to wake you up, so that if the child's having a convulsive seizure, you can go in and manage it with some midazolam or calling an ambulance. But at the moment, I don't think any of the wearable sensors can really pick up absences, but they could pick up the convulsive status.
Yeah. I'm just looking at the questions. Alison, would you like to ask your question about movement disorders?
Yes. So we have a 2-year-old who I believe, well, she obviously has some movement issues with core balance and stability, that kind of thing. And I was just wondering if we have a lot of therapies in place with her now, but projectively going forward, do those therapies tend to have impact on the overall outcome as she's going to get older? Or does the movement disorder sort of, it doesn't really matter too much? I mean, it's not that I won't try and do my best, but is it sort of shown that over time it doesn't really have a great effect?
Great question also, Alison. So the sad thing is that with therapies, we don't really know how much they do in a scientific sense. Now, I know a lot of my parents are now, or my families are now going to Napa, and they come back and say it's made a huge difference, and that's a very intensive program. And I think that does speak to their value. And also, I know that a lot of my older patients, particularly, I think, so when I say older, 10 years plus, over COVID, when they weren't getting their therapies, went backwards. It was a really common thing for families to tell me. So I do think the therapies help. But if I understand you correctly, the question is, does it affect the long-term outcome? For example, if they have stereotypies when they're 3 and you do say therapy, will they grow out of them or whatever? And my guess is with many of them, it will make no difference to that. Whether the therapy, but equally movement disorders come and go. So they could be there for a patch, say from 2 to 5 years, and then go away, depends on the disease and the gene. But does that mean you shouldn't use, I think with the floppiness, the lack of tone, I think you said your daughter had a low tone. I think the therapies are all we've got to do, and I definitely would be doing them.
Thank you. There's a couple of gene-specific questions, so sort of more consultation kind of questions, Ingrid. Although there's one question around, do you need to give up breastfeeding if you're moving on to the keto diet? Is that an easy answer, or is it individual?
I think it's probably individual. My recollection is no, but I've never had a baby that young go on it. But I know that people are recommending it. But because breast milk, I don't know is the answer, so I'm going to not answer that. Sorry.
Yeah. Okay. No, that's fine. We can explore that as more information comes to hand. I think we will stop it there. If there's any burning questions, people can please email me, and then I can try and follow up either with Ingrid or someone from her team. I just really want to thank you all for coming tonight, because I learnt a lot, and I always like to be in Ingrid's company just to absorb her knowledge, and just to thank Professor Scheffer for her time and for her dedication, because without her work, I know that my son wouldn't have a diagnosis, and we wouldn't have a community and an understanding of his condition. So grateful for your time, and hopefully we might be able to lock in an annual update with you.
Thanks, Chris. Thanks everyone for giving me your time.
Yeah. And just closing, the Epilepsy Foundation that I now work for is doing a lot of, my job is there to make sure that the genetic and rare lens is put across the work there. So hopefully you're starting to see a bit of a shift there in what we're doing. And yeah, reach out if there's anything you think we can be doing further to help families. I know there's a lot to do, but with all the researchers and clinicians and also the peak bodies working together, we can hopefully make that shift bigger and better. All right, thanks so much for your time, everyone.
Thanks, everyone. Good night.
No.
Night.